Welcome. Thank you, everyone, for joining us tonight. I'm David Eagleman. I'm the chair of the American Brain Foundation. And tonight we're going to learn about wearable technology for brain diseases. Our foundation is committed to sharing valuable resources and increasing public awareness of brain disease. So our webinar events like this one tonight are opportunities to connect you with experts in various topics of interest around brain disease. The American Brain Foundation funds research across the entire spectrum of brain diseases because we know that many of these diseases are interconnected, so that curing one brain disease may indeed lead to a cure for many. So let's move on to our topic of conversation for tonight, wearable technology for brain diseases. Neuromodulation devices are approved in the United States for the treatment of movement disorders, epilepsy, pain, and depression, and are used off-label for a number of other neurological indications. And I think as the science and the technologies advance, there's tremendous opportunity to explore new approaches and applications for disorders that range from tinnitus, which I think you'll hear a little bit about tonight, to stroke rehabilitation, to memory disorders, to mood disorders, brain and spinal cord trauma, and even Alzheimer's disease. So we have two fantastic guest speakers tonight, Dr. David Eagleman and Dr. Gregory Krauss. Dr. Eagleman is a neuroscientist at Stanford University, as well as a technologist and an entrepreneur. A few of his many projects include the PBS series, The Brain with David Eagleman, and The Creative Brain on Netflix. Above and beyond his 120 plus academic publications, he's published many popular and award-winning books. He's also the co-founder of two venture-backed companies, Neosensory and BrainCheck. And he also directs the Center for Science and Law, a national nonprofit institute. He's best known for his work on sensory substitution, which I think you'll hear about tonight, time perception, neuroplasticity or brain plasticity, synesthesia, and neurolaw. Dr. Eagleman is a TED speaker, he's a Guggenheim Fellow, and he serves on several boards, including the American Brain Foundation. So we're very proud to have him on our board. Dr. Gregory Krauss is a professor of neurology at Johns Hopkins. He focuses on the evaluation and treatment of seizures and epilepsy. He has a particular interest in treating medically resistant epilepsy, evaluating unexplained seizure-like episodes, treating seizures associated with tumors and systemic illnesses, and family planning counseling for patients with epilepsy. Dr. Krauss also evaluates patients who have failed standard medical therapies for possible treatment with epilepsy surgery and investigational medications, as well as devices such as vagal nerve stimulation. So without further ado, Dr. Krauss, you're up first. The floor is yours.
Okay. Thanks very much for inviting me to present to your audience. Can you see my screen now?
We can.
Okay. So what I'm going to talk about, and I'll try to keep it fairly short so we can have some discussion, but I want to talk about seizure detection and its possible role in preventing sudden unexpected death in epilepsy, which is a fairly recently acknowledged condition where patients following tonic-clonic seizures can have sudden death, which is usually a respiratory type death. And it's one of the major risks associated with having uncontrolled seizures. And let's see if I can make this work. Here's my disclosure, which is we do have a startup developing a seizure detector for the Apple Watch. And here's a typical patient, an unfortunate patient. This is a patient of mine, and a couple times a year, I get a call from a family where one of their family members died following a seizure. And so this was a patient who had uncontrolled seizures. He got placed on a new seizure drug that actually controlled his seizures completely. It's called cenobamate. Unfortunately, though, his life was improving and he moved from Philadelphia to Washington, and he packed up his medicine in his shipping container, and he missed several days' doses. And then he was heard to collapse in a shower by roommates and was found dead in the bathtub. And his autopsy was negative, just showing pulmonary congestion. And his mother was devastated. We brought her in, reviewed the autopsy, and these are just stunning events. And it happens over the given the cumulative risk of seizures, it happens in several percent of patients with epilepsy. And so this is something that we want to try to prevent. And I'm going to kind of go over a device that may help with this. So seizure detection and support apps can be very useful. It can increase independence and safety for persons with epilepsy. So for example, this particular patient, perhaps with the appropriate type of device, could have transmitted a warning about a seizure to caregivers or roommates and who could potentially help him. And so we think that seizure detection devices might reduce injuries and protect during seizures, and may actually help identify the risk for SUDEP, sudden unexpected death in epilepsy, since its major risk is having tonic-clonic seizures, and we have a detector that can detect specifically tonic-clonic seizures and log them and warn patients and caregivers about their occurrence. And so what do our patients want in wearables in this area for non-EEG seizure detection? We know they don't want, in general, implanted EEG systems or things that are stigmatizing. So what they say they want on surveys is they want wearable wristbands that don't stand out. They wouldn't mind having intelligent clothing, automatic seizure registration, seizure prediction is a goal. They would like it to make emergency calls to the family, and they would like appointments for physicians to help them optimize their device control. And they would participate in studies to do this. What they say they don't want is something stigmatizing or distracting, like a hat or cap device, or patches or glued or implanted electrodes. They don't actually want direct MD notifications. They want privacy. And so non-EEG systems such as Apple Watch that can detect seizures seem to be kind of a good approach. And so there have been a number of different non-EEG seizure detectors that have been developed. There's one that's actually built into the VNS device. It's a very high sensitivity, low specificity device, but it triggers stimulation of the vagus nerve generally hundreds of times a day. There's also other detectors that detect convulsive movements, EMG changes associated with seizures. There's an FDA-approved watch called Embrace that uses electrodermal and movement monitoring to detect seizures. And we have a detector using heart rate and movement and responsiveness. You can, interact with a person and say, "Are you there? Are you unconscious?" And you can actually test them in an interactive way using a watch. And so here's our detector, which provides monitoring for tonic-clonic seizures, caregiver alerting, and it asks right after seizures, it gives them surveys. Did you miss your medicine? Was there some stress trigger? Was it menses? And so that can help patients track maybe seizure triggers that they could potentially avoid. But it can automatically, load in diary results and do comorbidity screening, like drug side effect surveys can be loaded into this. And so when we developed this, we started this a while ago as part of a national study with Apple using a research kit program. And so we collected baseline data using a national recruiting study. And now we're studying it in our epilepsy unit for FDA clearance. But here's the kind of output you can get with a intelligent watch device. This is the seizure triggers reported by several hundred patients, right, with surveys done immediately following their seizures. And you can see stress, exhaustion, menstrual periods with hormonal changes. There's a variety of things that can increase risk for seizures. And this helps patients identify these things. Now, the biggest risk, though, for tonic-clonic seizures that can lead into sudden unexpected death is simply having a lot of tonic-clonic seizures, particularly ones occurring at night, and particularly in people who are unattended, who live alone or sleep alone. And that's shown in this graph. You can see the risk, the odds ratio for people with tonic-clonic seizures versus no tonic-clonic seizures but have epilepsy. And then in the other dimension, you can see whether they share a bedroom with a partner or not. And you can see a combination of risk factors that can lead to a high risk of having sudden death. And the biggest risk is having uncontrolled tonic-clonic seizures and sleeping alone, does not share bedroom. You can see that just standing up. So even if you have tonic-clonic seizures, but you share a bedroom with a partner, you can see the risk of SUDEP is pretty low. But if you're unattended, so there's no one to help you following a seizure, and the tonic-clonic seizure occur, there's a pretty high risk of SUDEP. And this has been, recognized. This is a practice guideline for the American Academy of Neurology and AES, just summarizing studies. And so nocturnal supervision to provide assistance during seizures helps reduce risk of SUDEP. And nocturnal listening devices can help too. People can use baby monitors and things sometimes to pick up seizures and go in and assist people who aren't sleeping right in the room with them. Now, here's what we're dealing with. This is the patient at the end of a tonic-clonic seizure. So he's having clonic jerking, which is gradually subsiding. That's what happens at the end of a tonic-clonic seizure. You get stiffening followed by clonic jerks. But what you can see is he's very limp. He's immobile. And then at the very end of the seizure, which is right now, he develops snoring behaviors. And the EEG goes flat. So following a tonic-clonic seizure, there's about 90 seconds of flat EEG with paralysis and this obstructed breathing pattern. And we think this is the biggest risk for SUDEP, where you happen to have a seizure in bed, particularly if it occurs face down, and you're not able to rescue yourself following a tonic-clonic seizure, which is a big exertional event. You may simply have, asphyxiation effects added to all the activation that occurs with a tonic-clonic seizure that can lead to a cardiac arrest. So we need to get someone in there right at the end of a seizure to turn them, stimulate them, and prevent asphyxiation. And so this shows us what our watch detects. On the second panel down, you can see the heart rate changes occur fairly late in the seizure, just correlating with the exertion. But in the bottom, you can see the accelerometer changes. What you can see is early, you see these very fine vibrations that's associated with tonic phase of a seizure, and then the broader, bigger amplitude changes that occur with the clonic phase of the seizure. And so particularly the tonic vibrations is a very specific pattern associated with tonic-clonic seizures that can allow you to identify seizures pretty specifically. There's very few things that emulate those tonic vibrations. Occasionally you can get fooled by someone running a gas engine that's vibrating like something like a chainsaw, which probably someone with seizure shouldn't be doing anyway. But there's a few motions that can imitate this, but generally this is a specific pattern associated with tonic-clonic seizures that can allow pretty early detection of seizures. And so we use this to detect seizures. And the goal is if someone has a convulsion, we detect the seizure, we alert a caregiver. They can go in and during this period of immobility and apnea and obstructed breathing, which we call sturdor, this snoring pattern after a seizure, they can stimulate then, turn them on their side, do a neck tilt chin lift maneuver to open up their airway. And we think that often prevents the complications that can occur, such as postictal hypoxemia and asphyxiation that can cause SUDEP. And so that's the goal of using a wearable in this case, is to prevent SUDEP. And so, the conclusion is I think these mobile applications can help patients and really improve safety and confidence in patients. So alerting caregivers can allow us to reduce SUDEP risk. This has been shown simply by this pattern where if you sleep with someone and have tonic-clonic seizures, your risk of SUDEP goes way down. So this gives you more independence. But it can also be used to improve medication adherence by tracking pill taking and seizures and monitoring drug side effects and giving feedback to patients and their caregivers. So this is sort of the path we're on in terms of using a wearable in a very specific way to detect tonic-clonic seizures and try to prevent this very specific risk of SUDEP. Every year we have a March on Epilepsy in Washington on the Mall, and there's always big groups of families carrying signs with pictures of their deceased loved one who has died of SUDEP. And so our goal is to try to prevent this tragedy. Thank you very much.
Dr. Krauss, thank you. Crucially important topic. For those of you who would like to ask questions, please put it in the chat or open up your mic or raise your hand afterward. But for now, we'll head to Dr. Eagleman and then open it up for questions after Dr. Eagleman finishes his presentation. Dr. Eagleman.
Okay, I'm gonna quickly share my desktop here so you can see some slides. All right, so tell me if you all are able to see the slide here. Can you see that? Yeah. Okay, awesome. Okay, great. So my interest is in how the brain constructs reality. And essentially the bottom line is your brain is locked in silence and darkness. It doesn't have any access to light or sounds or smells or anything. All it has is access to peripheral devices that convert those into spikes in the darkness. And so that's what allows us to experience our reality. And the thing that I've been interested in my lab for a very long time is this issue of, can we actually change the information that we're pushing into the brain? So I'm just going to give a minute of background here so you can understand what and why about the technology I'm going to tell you about. So our best proof of principle for shoving information into the brain comes from what's called sensory substitution, where you push information in via unusual channels. So an example is in 1969, a scientist named Paul Bacchi-Rita put blind people in a modified dental chair that had this grid that would poke you in the back, and he would set up a camera and put something in front of the camera, and whatever the camera saw, you felt that poked into your back. And so if it was a triangle, you'd feel a triangle in your back, or a face, you'd feel the face, and so on. And blind people could get pretty good at being able to understand what was going on in the visual world by what they were feeling on the skin of their back, which is pretty remarkable. And there have been many incarnations of this sort of technology. In this case, a blind person wears a camera, and what the camera sees gets translated into an audio input. So as you're, looking at things in the world, you hear and the blind person get really good at being able to understand what's in the world based on what's coming in through their ears rather than through their eyes. You can do this on the forehead with an electrotactile grid because you're not using the forehead for anything else. You can do it via the tongue. So this is one of the most modern incarnations where you have an electrotactile grid that sits on the tongue, and whatever the camera is seeing, you feel that on your tongue, like little pop rocks. And blind people can get so good at this, they can throw a ball into a basket or navigate a complex obstacle course, things like that. So this is the idea of sensory substitution, feeding information into the brain via an unusual channel. So my lab many years ago got interested in this question of, could we do this for people who are deaf, so that there's a sound in the world and a person who's deaf hears what's going on. So I'm not going to take my shirt off tonight, but here's a little clip that I gave it at the TED conference a while ago with a vest that I'd made. The vest has vibratory motors on it, and it's capturing sound, and it turns that sound into patterns of vibration from low to high frequency. So as I'm speaking, the sound is getting translated into dynamic patterns of vibration. I'm feeling the sonic world around me. Okay, so if you look at this carefully, you can see on the left, she's saying the word sound, and on the right, she's saying the word touch. And so you can see how the patterns of lights corresponds to the words that are being said. So our very first participant was a young man named Jonathan, who was born profoundly deaf. And so we had him wear the vest for 4 days, 2 hours a day. And here he is on his 5th day. He's sitting on the left. My graduate student, Scott, is sitting on the right. And Scott says a word. So he says the word you. And Jonathan feels the pattern of vibrations on his vest and writes down what he thinks he's heard there. So this pattern of vibrations is, of course, very complicated. He's not doing this consciously, just the way you don't consciously use your ears. So he's able to translate this pattern of vibrations into an understanding of what's getting said in the outside world. And National Geographic came to our offices a little while ago, and they were filming this gentleman, but it wasn't because of him. It was because of his daughter, who was born deaf and blind. And so we made a little miniature vest for her, and here she is feeling the auditory world around her for the first time. And what her grandmother's doing is taking her around and touching her feet on things and saying, this is soft, or this is hard, or, on the right, she's on one of these beds that's going up or down. And so the grandmother's saying up, 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 down, 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 down. And of course, that's how we learn how to use our ears, is just by correlations with things in the world. And so that's what's happening here. She's teaching her how to use the vest, how to come to hear through her skin. What we did after the vest is we shrunk this down to a chest strap for children who are deaf. And from there, we shrunk it down to a wristband. And the wristband has vibratory motors on it, and it's able to capture sound. It has a microphone and full computational capacity built in here. So it's a really nice little sleek wearable. And we have been on the market with this for 3 years now. And so for people who are deaf, it allows them to hear what's going on in the world around them. Here's our very first participant. He's wearing a much earlier prototype, but I'm just showing you this so you can get a sense of what it's like for him to be able to pick up on the auditory world through a wearable. So I'll just have you watch this for a moment. And so we've published this in the literature, a number of ways to show how well people can learn how to hear through this. I'll skip that, but I'll just say we're on wrists all over the world now. We're on wrists all over the world because this is a really useful and inexpensive device compared to the other options for people who are deaf. I'll get to that in 1 second. I just remembered I wanted to mention about this this word cloud that I'm showing here is just things that people wrote to us telling us that they were able to pick up on or were surprised by picking up on it with the wristband. These are people who are deaf who haven't heard before. Most deaf people, for example, have no idea that a microwave makes beeping sounds or that your, car blinker makes a clicking sound or something like that. So anyway, these were just things that we received from other people. Here's what I started to say is that, a cochlear implant is really the only other option for somebody who's deaf, and that's $100,000 and an invasive surgery. And ours is 100 times less expensive than that. So it's very useful. And that's why we're all over the world, especially in deaf schools. Now, I want to mention a couple other things. So it turns out that we recently published on this. What we have now is the best solution on the market for tinnitus, which is ringing in the ears, where people hear beep. And it turns out it's sort of accidental how we got here, but it turns out that what's called bimodal stimulation is the best thing you can do for tinnitus, which is you, in this case, have sounds, let's say, coming out of the app of the phone. It goes boop, 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 boop. And you're feeling, in our case, these vibrations on the wrist that corresponds. Every time there's a boop, you feel a buzz. And those are linked together. If you do that for just 10 minutes a day, it drives down the tinnitus enormously. And as I said, it's actually, peer reviewed better than any other approach on the market. So this has been a really big deal for us because we get so many emails a day from people with tinnitus. I don't know if anyone here has it or not, but for people who have it badly, it's really detrimental to their quality of life. And so this is something that just through a very very simple and almost accidental application of this technology is incredibly functional. So, and I'll tell you one other thing we've done, which is not accidental, which has taken us 2 years of work to get this in place. But we have a third thing, which is for high frequency hearing loss. So as people get older, they lose their high frequencies. And that's because high frequency sound has more energy. And so the little cells in your inner ear get killed eventually from all that high energy. And so it becomes harder and harder to understand conversations as a result. So what we're doing now is we're using very sophisticated machine learning on here to listen in real time for different parts of speech, an S, a D, a TH, an F. And it just buzzes in different ways to tell you, oh, I just heard a TH. Oh, I just heard an F, and so on. And so it turns out that your brain can learn how to combine the signals from your ear, which is taking care of the medium and low frequency, with the signals from your wrist, which is taking care of the high frequency. And in about a week or two, it seamlessly fuses these signals so that you just feel like you're hearing more clearly when you're wearing the wristband. And so we've been testing this for a while and improving the algorithm, and now we've been on the market for about 4 months. And so this has been a really big deal for us. And what we're hoping is to massively change the hearing aid market, because a lot of people don't want to wear hearing aids for lots of reasons. There's some people feel socially that there's a stigma there, and also it's just you can lose hearing aids, and by the way, they're more expensive. So that's what we're doing with the Clarify wristband. I'll mention 2 other projects we're doing that are very cool. Oh, sorry, that's just some data on it, showing that the Neosensory Clarify actually does better than hearing aids on average. But anyway, we can. That's on our website. Okay, but I want to talk about 2 other projects. One is a lot of people, about 15% of the population, when they get older, they lose their sense of balance, which is also a function of the inner ear, the vestibular system. And so they are not able to tell when they're standing upright or not. So what we did is something very simple. We built a collar clip with a 9-axis motion detector in it, and that talks to the wristband via Bluetooth, so that if you tilt, the collar clip tells the wristband how much and in which direction you're tilting. So it goes bzzz, bzzz. It tells you which way you're tilting. And so this is a very simple way for people to know if their vestibular system is not telling them, to know where their vestibular system is at any moment. We're also doing things with prosthetics. This is less a brain issue, but it is the case that when you lose a leg, you're not getting the data from there anymore. And so this is a way of artificially feeding the data to the brain, and the brain says, oh, okay, I got it. I know what my body is doing and where my leg is now. Okay, I think what I'm going to do is stop there, and we'll go, I guess, to questions now for either of us, me or Dr. Krauss.
Actually, we're just going to take them as they come here, David. Thank you very much. Living better through vibration. So the first question here is the alert, for Dr. Krauss, is the alert of the seizure forwarded automatically to the caregiver?
Yes, and you can designate several caregivers, and we're doing a study right now where it's not going to a caregiver because it's blinded. But it's in beta testing where there's signals given to the caregiver so they can assist the patient, sort of like what you saw with the nurse helping the patient during a seizure.
Great. By the way, they seem to nocturnal seizures are obviously a significant risk factor above and beyond the presence or absence of a caregiver. What do you think the mechanism is behind why a nocturnal, as opposed to a seizure that occurs during the waking hours, why is that such a profound risk factor for SUDEP?
Well, I mean, the biggest risk factor is just having a tonic-clonic seizure. But tonic-clonic seizures occurring at night, particularly when you're prone, can lead to asphyxiation. Patients are often found in multiple autopsy series across many countries, like Iceland, New Zealand, Australia. The majority of people are found face down, usually with their bed clothing around them or on the floor. And so I think this postdictal, post-seizure EEG flattening, we call it postdictal EEG suppression, is associated with immobility and just paralysis. And they have this obstructed respiratory pattern. And I think in bed in particular, it's a time where people are often not observed, and they could asphyxiate if they're face down during a seizure. They can't turn themselves off their face.
Are there cardiac risk factors, for example, prolonged QT or other predispositions?
Well, a lot of people have looked for risk factors, and there's a whole list of things that have been investigated. I'm of the view it's closer to like when you drive a car and crash, about 1 out of 500 crashes, you hit the tree. And if you have a lot of tonic-clonic seizures, I think you have a lot of risk. During a tonic-clonic seizure, you have hypoxemia, you have your lactic acid goes way up, your cortisol goes up, your heart is racing, and you're getting hypercapnic, your CO2 is building. And so after a tonic-clonic seizure, it's like running a 400-yard dash. You need to recover. And so if you happen to be face down or obstructed in your breathing, you don't get recovery, and that can lead to a PEA arrest, which is sort of a respiratory-driven cardiac arrest. I think the mechanism of SUDEP is very similar to in police custody deaths when they get on people's backs.
Interesting. Dr. Eagleman, since tinnitus has a myriad of causes, does the bimodal device demonstrate better efficacy in any specific subtype?
Yeah, it's a great question. So there are many different ways that someone ends up with tinnitus. We don't know yet exactly what subtype it's best for. It works for the majority of patients. For about 87% of people, they see clinically significant improvement. I wear two hats. One as a scientist and one, running this business, Neosensory. But what we do at Neosensory is we just give a 30-day money-back guarantee. So anyone can try it. If they do it for 30 days and it's not working for them, they just get their money back. So that's how we get around the fact that 13% of people don't show improvement. Nobody gets worse.
Yeah. What do you think the mechanism is? I understand the sensory substitution, but what do you think the mechanism is by which it drives down an internally generated sound?
Yeah. So people have made pretty sophisticated arguments about this in the literature, but I actually think it's a very simple story, which is you're teaching the brain what is a real external sound, because every sound, boop, gets a verification on the wrist. Bzz. And so every sound gets confirmation, but your internal tinnitus beep, is not getting any verification on the wrist. And so your brain realizes that's fake news and it drives that down.
Huh. Very good. Dr. Krauss, is the Epi Watch FDA approved, or will FDA approval be sought?
We're just finishing a clearance trial for our release, but we're actually most of these devices have been studied in epilepsy monitoring units where patients are brought in for a week or so, and you lower their medicines and you test while you're doing video of seizures in a controlled environment. We're starting an outpatient trial though with ambulatory detection, which is much more challenging. But kind of the secret sauce of our detector is that it has very few false positives. So we're going to move on and do ambulatory study. And so people with uncontrolled tonic-clonic seizures, we will be recruiting people to join kind of a national study on tonic-clonic seizure detection in an ambulatory setting, which means, not in a seizure unit.
Okay. Dr. Eagleman, has the Clarify been studied in older adults with cognitive impairment due to MCI or dementia? And might interpretation of the tactile signals differ among those with cognitive impairment versus those without?
We haven't yet done that carefully. And in part, it's because we've been doing so much testing. And so we find people who have high frequency hearing loss and can get the instructions and how to use the app and so on. I have a suspicion that it would still work because originally when we made this, we built a whole training program for people. And then we realized you don't actually need that. All you need to do is be in the world and exposed to sound. So for example, if you speak, your voice is triggering the phonemes here, the sounds of S or T or F or whatever, and so your brain figures it out. And even if you just listen to television or listen to audiobooks, your brain is figuring it out based on probability of what was the word that must have been said. So we don't need any particular training. So in theory, even if someone has dementia, this is very low level learning going on. I suspect that it would be okay, just so long as they're willing to be around, television and audiobooks and that kind of thing.
Right. I guess a question for either of you, is any work being done with wearables for tremor disorders?
I can answer that. Actually, there's a rumor on the street that when somebody has a tremor, if you give them a little zap at just the right moment each time, you can make the tremor go away. And of course, that's because the tremor has to do with signals coming out from the brain and signals returning from the brain, and they're not being timed quite right, and so that's why it keeps doing this correction. So essentially you're swamping the signal and just doing something, and that makes it go away. So that's something we're going to be trying. All we need to do is modify this to put a motion detector inside the wristband itself so we can see when the tremor starts. So check back in 3 months. We'll know the answer.
Let's see. Here's a question. I guess this is just a general question for Dr. Krauss, and that is, what's been your experience working with Apple as a partner on product development?
Well, I probably misspoke when I said that we did that initial study with Apple. They are facilitators, and they provide, ideas, devices, access to their devices. And so we started by using the research kit program that lets you do e-consenting and do national studies using electronic consenting, which is actually a big issue to be able to do that. So they helped us get over that hump. We could ask for advice, and we used their watch, but I wouldn't view them as partners. They're more like, they provide devices and software and research support software.
Yeah. Dr. Eagleman, does tinnitus recur when the device is no longer used? In other words, is this a lifetime commitment?
No, actually, the cool part is it drives the tinnitus down, and then as far as we can measure, which is 1 year so far, it stays low. And actually, there's another group in Ireland that did a study. They're also using bimodal stimulation, but they use headphones and a thing on your tongue that shocks you. And so ours turns out is much simpler. But anyway, they also showed that it lasts for a year. So that's really good news. So actually, we structured that as a rental program. So people rent the wristband. It gets shipped to their house. They just use it for 10 minutes a day. And after 2 months, they ship it back to us.
What's the average amount of time before people notice benefit? Like you said, you get a 1 month money back guarantee, although your data was over a 3 month period, if I'm not mistaken. So is it duration dependent that you see benefit? And when do people start to notice the benefit?
Yeah. So you see the biggest effects in the first 2 weeks, and then it keeps going a little bit. And by about 8 weeks, you've essentially plateaued. So at that point, we just have people send it back. There are a lot of people who will rent it for a 3rd month or a 4th month just because they want to, but about 8 weeks is about as big as you're going to see. But in answer to your question, it's the first couple of weeks where all the action really starts happening. So you'll know in plenty of time whether it's going to work for you.
Yeah. Dr. Krauss, any benefit for the Epi watch in people who have what someone says is focal aware seizures or maybe partial complex seizures, simple partial seizures, any other seizure types beyond generalized tonic-clonic seizures?
Yeah. So first, there's not a significant risk, or it's a pretty rare occurrence to have SUDEP with focal seizures. Occasionally, people with temporal lobe seizures can have bradycardia rather than this postdictal respiratory problem. So our detector doesn't detect non-tonic-clonic seizures. It can certainly characterize them and can show if nocturnal events are occurring, and it provides a lot of sort of support with diaries and drug side effect screens, but it doesn't detect focal unaware seizures. It can profile them very well, though, with that activity accelerometer data and heart rate changes. You can often characterize individual seizures, but it's not real reliable in terms of warning others. But also the risk for those seizures is much less than for tonic-clonic seizures. Almost no one gets postictal EG flattening and respiratory compromise following a focal seizure.
Right. Dr. Eagleman, one of our attendees this evening has multiple sclerosis, a foot drop, and tinnitus. And the question is, could one wristband help me? And I guess the extension of that is, have you had patients with multiple sclerosis, tinnitus related to that, and have they improved?
So again, I don't know about the etiology of the tinnitus, what it helps for. It may be that the MS is what caused the tinnitus, or it might be independent from that. So I can't say for sure, but you've got an 87% chance that it'll help you.
Yeah. Another question, Meniere's disease. Have you seen it work in people with Meniere's disease?
I don't know yet, although our balance studies right now, we're just dealing with sort of garden variety vestibular dysfunction where people have a problem with balancing, but it's going to be one of the things that we study over the next year is how this works for Meniere's.
Question here, any possibility that sensory substitution might help with patients with anosmia? Would words and colors, for example, make a person recall an olfactory sensation, which is lost due to either traumatic or disease related to anosmia? This assumes they had normal olfactory sensation prior to the events that caused the loss of smell.
That's an interesting one. The general story is if you have a sense and lose it, then you can have triggers that remind you of it, the smell of cinnamon, or maybe you grew up in some other country and someone tells you, oh, remember that smell when we were kids, and you can recreate it. So generally we're good at it. But as far as whether sensory substitution could help with anosmia, which, sorry, for anyone who doesn't know, that's, a lack of smell. One of the things we're working on now is using artificial molecular detectors to pick up on smells and tell the wristband, oh, I'm detecting this smell or that smell. And actually we had a conversation with the Drug Enforcement Agency of a different country who's interested in being able to, instead of walking around with dogs to smell everything, just having one of these that picks up on the artificial, that picks up on the molecules of ice or cocaine or other things and just tells you, so when those things are present. You don't need the dog.
Mm-hmm. Does sensory substitution help with Parkinson's disease beyond what you said about tremor?
Yeah, there are three things actually that I want to do with Parkinson's. So one is, you may know that people with Parkinson's tend to have balance problems. So obviously the collar clip helps with that. Number two is the tremor. The third one has to do with gait freezing. So people with Parkinson's disease, typically they're walking and then they'll just stop walking. And so I published some data on this a while ago that, auditory rhythms will get them walking again. If you go beep, 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 just the rhythmic nature of it will get somebody walking again. So I'm interested, we haven't tested these yet, but I have a high suspicion that a buzzing will also, so it goes bzz, 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 when it detects that somebody has stopped walking. So my idea is one wristband takes care of tremors, detects when you've stopped walking and gives you a gentle buzz to keep going, and it also takes care of the balance.
There's a question.
By the way,
David.
So I saw a question earlier just asking whether somebody can use Clarify along with hearing aids. A lot of people actually do. They use whatever tech they have, either cochlear implants or hearing aids, and the wristband also. And what they say is it just really helps because they're getting three data sources now. They're seeing what someone's lips are doing. They're hearing whatever they're hearing through their technology, and they're getting the buzzing here. And collectively, that sharpens their estimation of what's going on out there.
Do these devices have FDA approval, David?
No. So we got out on the market fast with this. These don't need FDA approval. We are at this point going for the FDA approval path, but we're already on the market without it.
There's a question here, Dr. Krauss, about brain tumors and menopause. Has any study or research been done on it?
Well, yeah, I mean, there's a huge amount of literature on both those topics. In terms of menopause, there about 30% of women have menstrual-related seizures, and we were involved with a big study where we gave them back progesterone, which is a neurosteroid and triggers menses when it drops and can release seizures. And that was actually not effective. The seizures just got more scattered. At menopause, you see a similar thing, like Dr. Alan Krumholtz from University of Maryland. He looked at seizure patterns around menopause, and they often became more scattered, weren't as linked to menses. But the actual number of seizures varied. About a third of people, the seizures decreased, and about a third, they went up slightly.
Mm-hmm.
But any brain tumor can trigger seizures. There's special ones that are congenital or part of development that are particularly associated with seizures. But, those are common causes of seizures. Seizures come from the boundaries of tumors generally.
Yeah. Dr. Eagleman, the bimolar stimulation, when people are applying it for the 10 minutes, is there more of a suppression of the tinnitus than the other 23 hours and 50 minutes when they're not applying it?
That's a good question. I don't know, actually. It's a slow, each day just gets a little bit better, but I don't know if you can, that's a great question. I will start asking people that about their experience.
Yeah. Is there a dose response? How did you arrive at the 10 minutes? I mean, why not 30 minutes? Why not an hour?
I tell you, it's because we tried all of those, and a lot of people actually, they say, okay, even though you're telling me 10 minutes, I'm going to do it for half an hour, whatever they have time for. So we have a lot of data of people using it much longer than that, but it doesn't appear to be any better, meaningfully better than just doing it 10 minutes. That's how we landed on it, by looking at lots of different times.
Question here about the cost of the Clarify wristband.
It's $1,000, which is 5 times cheaper than a good pair of hearing aids.
And then there's a couple of questions here about, all kinds of questions about different applications of these devices, including vestibular migraine. Migraine, obviously there's 1 billion people in the world with migraine. A lot of them have tinnitus. A lot of them have vestibular dysfunction. And then the other one is dystonia.
Yeah. I don't know what we actually have 70 projects going on that we're testing. So we're very busy, but we're not capturing everything. So I don't know whether it'll be useful for migraines or dystonia, except in as much as we're helping other issues like the tinnitus or the balance.
Yeah. Though vestibular migraines are markedly helped with physical therapy, with vestibular training desensitization. Yeah. And I would imagine it'd be nice to facilitate that physical therapy using devices.
Yeah. Yeah. Cool. And of course, there are a number of devices that are approved for migraine right now. I think there's 5 on the market. They're stimulating something different, but from the vagus nerve to the trigeminal nerve. But let's see. I think we covered all of the questions that were in here. I think we covered all of the questions. Anybody have any other questions for our 2 experts tonight? You want to open up your mic? Of course, I can't see if you raise your hand because there's so many people here tonight.
Somebody's asking, is the wristband covered by insurance?
Not yet.
Mm-hmm.
Just like hearing aids aren't, unless you're a vet. Yeah. If someone has hearing loss and tinnitus, yes, it works for both. It's an all-in-one thing. So you use it in the Clarify mode most of the time. Then 10 minutes a day, you just hit a button on the app to do the tinnitus training.
Yeah, great. I think that's all of the questions tonight. So, listen, to both of you, Dr. Eagleman and Dr. Krauss, thank you. This was really excellent, showing us where neuromodulation is, where it is now and where it's going in the future. It's pretty exciting technology to be able to give patients back sight and hearing, and to be able to ensure, one question I did have before I close for Dr. Krauss is, some people with generalized tonic-clonic seizures who simply do not have a bed partner. I'm sure that happens to you quite a bit in your practice. What do you do in those situations?
Well, the first thing is the major risk for SUDEP is having tonic-clonic seizures. And you really shouldn't put up with having tonic-clonic seizures. The device can tell you if you're having tonic-clonic seizures because our detector is pretty specific and doesn't really have very many false positives. So if you do have that, you should hound your doctor. There's several newer medicines that have been released in the last few years. One of them reduces or completely blocks tonic-clonic seizures in 90% of patients with those. And so it's really just important to optimize treatment. But, you know, if you're having uncontrolled tonic-clonic seizures, it is helpful to have, you know, someone around you. I've seen many patients who've died living alone.
Yeah. Well, the last couple of comments were very interesting. Thank you for your time and efforts and excellent presentations. And so I just want to reiterate that. Thank you so much for giving up your time with us tonight. And thank you all for attending. We'd love to see you come back again. We have a great lineup of monthly webinar schedules, including a talk about diversity, equity, inclusion, and autism research with Dr. Audrey Brumbach, and that's on May 22nd. So please join us for that if you can, and you can also follow us on social media to stay up to date on all brain diseases, information and research that we're doing, that the American Academy of Neurology, our partner, is doing, and that many of our junior clinician scientists are doing as well. So thank you all very much for being here tonight. Have a great night. Stay safe, and we'll see you next time.